Hello everyone. I'm here tonight to give you a video about the respiratory system, and we're going to also cover the upper respiratory system diseases. So let's get started. Pretty much what we want to start with is a little bit of the anatomy of the respiratory system. And for you to understand that within the alveoli, which is that parenchyma, which is the functional part, it's where the exchange of oxygen and carbon dioxide happen. So we breathe in this air, this oxygen, and it goes all the way to the alveoli where it exchanges for the carbon dioxide the byproduct that we produce, and it's done in that capillary system. And then from there, we expel it out again to, to the environment. And this is constantly happening, and is definitely necessary to maintain balance in the body. The respiratory system is divided into two categories, so to speak, the upper and the lower respiratory tract. And we have different mechanisms, from the nose to the little hairs that we have in our nose that filter this air, help us to prevent from organisms like bacteria and viruses to actually reach the lungs where they're supposed to be. We'll call it non-welcoming to bacteria. So I put a little picture here of the different areas that we have on the upper respiratory system. So we're going to be talking about the larynx, the oral cavity, the sinuses, the bronchis. And so just so you know when I'm mentioning these names, what they are. So let's talk about what are some risk factors that cause respiratory diseases. Well, there's many factors, and in class, I'm going to ask you to scan this code, and basically you tell me which ones you think they are. But for this lecture, since this is a review, I'm just going to tell you. And it includes basically personal and family history of lung disease. Smoking is a big one. Think about, when somebody smokes, they're just inhaling all these toxins and chemicals and tobacco. It's very harmful to the tissues in that parenchyma of the lung. Sometimes also certain jobs, like for example, someone that works at a mine that is constantly exposed to minerals and these dust of the mine. Another risk factor are if you have constant respiratory infections. That includes all the way from child, from young to older. Another risk factor for respiratory issues is if you've had any respiratory, surgical or post-operative changes. So for example, maybe you had an abdominal surgery and now you're not taking deep breaths. And then from there, you develop atelectasis, that we're going to talk about that a little later. And you develop pneumonia, which is a disease of the respiratory tract. So think about the mechanisms that help us maintain a healthy respiratory system, like our cough reflex, the little hairs in our trach and also in our nose. And so those things, when they're altered, then you can be at risk for also problems in the respiratory tract. The next thing is to talk about what happens whenever someone has low oxygenation. Well, there's many things that could happen. Remember, we need oxygen. The cells need oxygen. to basically live. We can't live without no oxygen. And so early symptoms are restlessness, irritability, confusion, lethargy. Maybe you start breathing a little bit faster because you're trying to get more oxygen. Your heart starts pumping a little bit faster as well because you need more oxygen. Your blood pressure increases. You can also have shortness of breath or fatigue. Now, late symptoms are maybe you're combative at this point, or you have shortness of breath just while you're at rest, or you're using your accessory muscles and you have retractions, and you can see someone like literally gasping for air and huffing and puffing. And then, of course, whenever we don't have oxygen, your organs start deteriorating. So you can have a drop in blood pressure, you can have cyanosis, this blue discoloration on your lips, on your tissues, and so on. There are different diagnostic tests and studies that we can do to diagnose something related to the respiratory system. And throughout the lectures, whenever we talk about lower and upper respiratory diseases, I'm going to be discussing some of these, but in general, I wanted to give you an idea of what they are. So we can do blood studies like laboratory with your blood that can basically tell us your white blood cell count, which could say you have an infection. Or maybe you have arterial blood gases. And whenever we discuss acid-base imbalances, you're going to learn all about the ABGs. You can have sputum cultures, you can have chest x-rays that can tell us how is the air effective or being in the lungs, if it's filled with fluid or pus or whatever. You can have CT, MRIs. You can have bronchoscopies, which is like a tube down your nose up to your trach or trachea, and they basically visualize the structures and they could collect samples. You can also have a thoracentesis, which is a needle through that sac that covers your lungs, and they can aspirate fluid. You're going to learn a little bit more about this later on. But anyways, in general, there's different diagnostic tests. I really encourage you to go into page 472 to 473 and look at them. They have different nursing diagnoses or considerations. And the different things that we need to teach our patients. I'm just going to touch just a few that are very important. So bronchoscopy is, as I mentioned earlier, they go all the way to your bronchis and part of your little areas, smaller areas on your lungs. And they can visualize all this tissue, all the structures. They can take a biopsy if they need to. For someone going to have a bronchoscopy, because it is invasive, they have to have a written consent. They have to be MPO for 6 to 12 hours before the procedure. That is because you're basically bypassing this gag reflex here, and you don't want someone gagging, vomiting, and aspirating. So you want to protect the airway. So therefore, they put them NPO 6 to 12 hours before. You give them some sedative, this conscious sedation thing or cocktail for them to be like not completely under anesthesia, like general anesthesia, but then for them to be just kind of groggy. Post-procedure, this is kind of where you're possibly going to see them when they come back to the floor. They're going to be MPO until your gag reflex returns. Their mucus might have a little tinge of blood, and that's normal because if they took a little piece of biopsy, a little piece of that tissue, it could bleed. And so you don't want anything excessive blood, but you could see a little trace of blood. Because you're going with something sort of hard, although it's flexible, but it's hard, you want to watch out for hemorrhage or a pneumothorax, where you penetrate basically the sac, and then the lungs fill up with air, and it compresses the lung. So you always want to be assessing a lung sounds, watching the gag reflex, watching for any excessive blood, and so on. On the thoracentesis, as I mentioned, is a needle that goes in the back of your back, in that sac or that area around the lung, to remove or aspirate pleural fluid. And so you're going to learn later on when we talk about pleural effusion that this is one of the things that happens. And then the pleural cavity fills with fluid, and that compresses the lungs, it pushes the lung upwards, and then the patients can breathe correctly. So again, it's an invasive thing, so you get a consent. This could be done right at the patient's room, like at the bedside. They just kind of sit the patient just like this picture, lay their arms like that on the bedside table. The doctor aspirates in the back. Sometimes they could take big old liters of fluid, and then they send that fluid for culture. Again, you want to evaluate the sounds of your lung sounds. Watch for bleeding, watch for pneumothorax. And after they remove the fluid, you want to encourage your patients to use the insular spirometer so they can expand those lungs, and the lungs again regains their size. Another thing that is a diagnostic test is a ventilation perfusion scan, or a VQ scan. In here, basically, the patient gets two things in one. They're looking for the ventilation, like how much air is passing, but they're also looking at the circulation, the perfusion of the lungs, like within the veins and within the arteries. And so it's nuclear. They do like radioactive agent. And it's pretty cool. We use this to diagnose sometimes pulmonary embolism, which is a clot in the lungs, or other things. So I just gave you a brief overview of the respiratory system. So now let's talk about upper respiratory problems or diseases. So again, we're going to talk kind of like just trach up. We're not going to touch anything related to the lower respiratory system. For that, I will give you another video. So the first thing that we're going to talk about in the upper respiratory system is allergic rhinitis. This is your common allergies that a lot of people experience. It's an inflammation of the nasal mucosa, so the mucosa that overreacts or just reacts to a specific allergen. So your immune system is like, whoa, I do not like this pollen that you just had me inhaled because you were out in spring doing your garden, let's say. And the immune system is like, whoa, sends all these mediators and basically inflames or makes your mucosa swollen. And this could happen, like somebody can experience this like constantly. Some people have chronic allergies, and some people could just have them like just, hey, in different or particular times of the year. For example, spring, whenever you have all this pollen flowing around. The clinical manifestations, or how basically the patient presents, is just your allergies. I'm sure maybe A lot of you guys have experienced some allergies before. You get that sneezing, you get the itchy, watery eyes and nose. You get maybe a thin, clear nasal discharge or drainage. Sometimes it can provoke a cough, and that cough, most of the times, is whenever you lay flat or you are in a more leaning position, because the clear mucus just kind of goes through the back of your throat and it tickles your throat. So we call that a post-nasal drip. You can have altered sense of smell or taste, even maybe some nasal congestion, which can cause a headache and hoarseness. There are different types of allergens can cause this, and they're on page 480. I'm just going to mention a few, like dust, pollen, dust mites in the house, spores, smoke is a big one. But again, it just depends on what your immune system is responding to. And many people are different. Everyone is different. So how do we treat it? Well, we treat it with first identifying and avoiding this trigger. So if it's the pollen, because it is spring, well, you try to avoid as much possible activities that are outside whenever it's high pollen season. If it is perhaps dust at your house, maybe you have to rip the carpet, or you have to clean often, or you have to cover yourself when you clean. So patient education here is a key, is important, and is vital. It's on page 480 of your book. So some of the things that we recommend for patient, or we educate them, is keep a reaction and activity diary. Like, okay, well, I started having allergies after I was doing and mowing my yard. Well, it's probably because the pollen from the grass. Also, another thing is remove carpets, wash the bed sheets in hot water. Some people cover their bed sheets with plastics because of dust mites. Vacuuming frequently if you have carpets, although it's recommended not to have carpets. Maybe your allergies come from pets and you just have to, unfortunately, maybe rehome them, find a new home for them, or avoid pets. Excuse me, avoid activities outdoor on that big seasons, and avoid smoke. So besides identifying and avoiding the triggers, we do have some medications that could work and that are very effective. Now, but compliance is very important. So the first line of treatment are nasal corticosteroids. They end in zone, fluticasone or Flonase. You can buy this over the counter. You also have memortazone, like Nasonex, and you just do your nasal spray a little bit, maybe once or twice a day, and you combine it with an antihistamine. An antihistamine basically is telling the immune system, stop this histamine triggers that you're sending to me. And so it blocks them. Now we have first generation and second generation antihistamines. The first generations is your commonly known Benadryl, diphenhydramine. They end in "-ine". And now the problem with this first generation's antihistamines is that they make you drowsy. And so they make you sleepy. You can't operate heavy machinery and stuff like that. But with the years, we have come up with second generation antihistamines like loratadine or Claritine and cetirizine, Zyrtec. And there's many more. I'm just giving you some common ones that I'm sure I've seen and you can find over the counter. These second generations do not have these side effects of dizziness or drowsiness or sleepiness. Now they all cause dryness. They dry your eyes, they dry your mucosa, and they dry every tissue. So you got to drink plenty of water, because it will constipate you, it will decrease your urine output, etc. It will make your also your tongue dry. Then you also have your decongestions like zoodoephedrine, um, commonly known as Sudafed. You can buy this over the counter as well. They decongest the mucosa. So whenever it's so swollen, patients can't breathe and everything gets like stuffed up. So these decongest the client. Another medication is leukotriene receptor antagonist. They end in cast, montelukast, or Singulair. Now, some people have allergies chronic and they've tried the antihistamines, they've tried the nasal corticosteroids, and it just doesn't cut it. So your doctor might prescribe doing a long-term medication like leukotriene receptor antagonist to keep you controlled and to make sure that your immune system doesn't constantly react. Going back to the pseudoephedrine or Sudafed, I want to also let you know that with Sudafed, you have to be very, very careful because in great quantities, it can cause tachycardia, palpitation, elevate your blood pressure. So we want to educate our clients to be careful, and really is not recommended on cardiac patients. Okay, so be careful with tachycardia, palpitations, and high blood pressure. There is an immunotherapy, allergy injections that patients can have whenever they suffer from big time allergies, where they introduce just a little bit of the allergen, little by little, and in small quantities, so that way your immune system kind of gets used to it and doesn't react as strong. The next disease is your good old influenza or flu. I'm sure this is not the first time you guys have heard influenza, but let's cover it and let's go over what you really need to know. It's high mortality, high morbidity. People die every year of influenza. It has its peaks between September and April. Every year, there's different variants because it's a virus and the virus mutate. And so every year there's a new type or strain, we call them. And so therefore, that is why the flu vaccine is yearly, because they customize that vaccine based on the strain that is going on. It is droplet. It is easily transmitted by just a sneeze, a cough. Droplets just basically travel through the air and someone inhales them. The manifestations, well, you get your typical high fevers, headache, body pain from the fever, sore throat. Sometimes you get cough, fatigue and weakness. And yeah, you can have some congestion and some drainage as well from your nose. They usually can last 7 days if it's not complicated to something else, because influenza can complicate to bronchitis, it can complicate to pneumonia. But the big one is pneumonia, and that's what leads the patients to die. Another complication could be ear and sinus infection or even respiratory failure. So your big ones are respiratory failure and pneumonia. And we're going to learn about pneumonia in the lower respiratory system. So you'll know what pneumonia is later on. We diagnose it by the symptoms of the patient or your good old rapid flu test that they swab your nose and boom, it gives you a result very quickly. So to treat it, prevention is key. So therefore, we wanted to prevent it, and we prevent it by doing good hand hygiene and good hygiene etiquettes, getting your influenza vaccine every year. You can get the inactivated or the live attenuated, and there is a difference between those two. They're in page 484. The inactivated is the weakened virus being injected in your muscle. The live attenuated is usually a spray, and there's certain ages you can get it. And so please go to that chart in 484 of your book and see the difference, okay? It takes about 2 weeks to create antibodies. So a lot of people, what happened is that they don't believe on the flu vaccine because they get the vaccine and maybe a few days later they get influenza. Well, they didn't get it from the vaccine. They got it because they think that by being vaccinated immediately, that woohoo, you are protected. And no, it takes 2 weeks to create antibodies. There is antivirals that we can give patients. The commonly one is Tamiflu. They finish in Mivir, so oseltamivir. It's one of the most common ones, but here's the caveat with this antivirals. They don't cure the flu, or they don't prevent the flu. What they do is that they shorten the duration of the symptoms, and they help for you not to develop complications, but you have to take them within the first 2 days of the onset of the symptoms. If you've been with flu symptoms for a week, taking Tamiflu, it's not going to work. It's not going to do anything, okay? It has to be within the first 2 days of the onset of the symptoms. Anybody, especially for the inactivated, anybody above the age of 6 months can get it. And people at high risk. Who are at high risk? Well, your healthcare workers, your residents of long-term care facilities, and anyone with comorbidities like COPD, diabetes, hypertension, renal problems, all these diseases that you're going to be learning little by little. There are some contraindications for someone to get the flu vaccine. For example, if you've had allergic reactions to it before, or if you've had Guillain-Barré, which is a nervous system disease. And you want to also encourage the patients to rest, hydrate, take some analgesic or pain reducers for their pain in their body or their fever, and eat well. And remember, your body heals whenever we eat and we rest. Okay, moving on to the next problem, which is sinusitis. Sinusitis is an inflammation or swelling of the mucosa that lines these openings that we have right here under our eyes. They're called the sinuses. And so whenever they swell and they fill with mucus, it blocks basically everything, and all that starts getting infected and inflamed. And that is what sinusitis is. It could be viral or bacterial. It could be acute, it could be chronic. and it could last for weeks sometimes. Typically, maybe you start with some allergies, you don't treat them, and boom, it develops into sinusitis. Um, Typically, sinusitis is diagnosed with just the symptoms of the patient, um, and by the doctor just pressing right here above your sinuses. And if that hurts, they usually diagnose you with sinusitis. If it's chronic, yes, you can do an endoscopy and some CT scans, but not for the acute. The manifestations are pain and pressure over your eyes and right here in your forehead, which can lead to a headache, fever, stuffy nose. Your drainage from your nose is nasty. It's yellow, it's green, it could even be brownish at times. You lose your taste and your smell because you're so congested. You feel ill, you feel fatigued, tired, you can have some sore throat, and you can have some cough. There is a big correlation between sinusitis and asthma. And whenever we talk about asthma a little bit later on a different video, I'm going to bring it up again. But yes, people that develop asthma or have asthma, they really need to take care of upper respiratory infections very quickly, especially sinusitis. How do we treat it? Well, again, it's usually a complication of something, especially or mainly this allergic reactions. So therefore, identifying and avoiding triggers is important. We do have the drug treatment to basically treat the symptoms. Because if it's viral, we cannot give antibiotics. Now, if it complicates because it's lasting more than a week, then antibiotics could be appropriate. But initially, what you're going to do is decongest the client with oral decongestants like Sudafed, because the sinuses are so clogged up that they can't breathe. You're going to use intranasal corticosteroids like Flonase, which we discussed these previously, analgesics for pain or fever, maybe some saline spray or warm damp towel over your sinuses, or a hot steamy shower to get that steam and help the patient breathe. If you need antibiotics, then a go-to antibiotics is amoxicillin, and it's given 10 to 14 days, or you have something called amoxicillin with clavulanic or augmentin. And so it depends on your history, depends on the doctor they'll give you. Again, I want to tell you, and I'm going to repeat myself, that be careful with Sudafed in cardiac patient. It can cause tachycardia and palpitations or elevated blood pressure. So we want to teach our patients that develop sinusitis to rest, hydrate a lot, 6 to 8 glasses, humidifier or hot steam showers, nasal saline, a warm damp towel over the sinuses. It's okay to sleep with your head elevated. It helps to drain the mucus, and it helps with your cough as well. Same with whenever you have allergies. Take your medication, avoid any smoking or being with someone or around smoke, and prevent and remove any of the triggers that are causing sinusitis. Okay, these are just my references. I referenced the book, which is your book, and all the images that I obtain are from Google or the book. Okay, I hope this was helpful, and I will come back with another video of the lower respiratory diseases. I'll see you in the next video. Bye-bye.